Hi, I am Hannah Abdullah, senior staff, and Dr. Iman, junior staff in our radiology center. Now we will approach this case using a SNAP technique. So, Dr. Iman, tell us about your case.
47 years old patient presented by recurrent attack of bleeding the rectum. The clinician asked for CT colonoscopy. Two sequences are taken, one pre and post inflation. Our CT finding was 5 cm long segment, rectosigmoid segment, bowel wall thickening, marked smudge surrounding fat planes, regional air clusters in the nearby mesentery. One of these clusters are seen sizable.
So this is your findings for what's your differential?
It is neoplastic, or inflammatory diverticulitis.
So you suggest any of which?
I think it's diverticulitis rather than neoplastic.
You find some diverticulum in this bowel wall.
Yes.
And however, also this paracolic inflammatory status could be also a complication for neoplastic. But you find any other findings suggest an neoplasm?
I didn't find it. No lytic or sclerotic bony lesions. No
Suspicious lymphadenopathy, right? The liver needs further evaluation by
conducted by triphasic study.
So you may recommend further management for this case?
I think CT with IV and rectal contrast is needed, and colonoscopy to differentiate between both of them.
The CT IV contrast may add for verification of the liver, right?
Yes, and of the paracolic, the sizable cluster.
The rectal contrast may verify this
cluster could be paracolic abscess.
Also, the iliac loops, what do you think about iliac loops? It is a little bit dilated.
Oh, yes.
And distended with air?
Yes.
What's your interpretation of this?
It could be fistula.
Yes, or just
ileocecal
valve incontinence.
Yes.
Right?
Yes.
So this iliac loop distension may be really an anterocolic fistula. So your suggestion, which is contrast injection via the rectum, may add in verification of this complication.
Yes.
However, it also may carry a burden for the patient, right?
Yes.
It may cause peritonitis, flare up of this inflammatory status, right?
Yes, I think yes.
So may we need to communicate with
the clinician.
With the clinician surgeon. May he be referred to just open and see, and prepare himself for this bad surprise if present,
yes,
without loading the patient further risk for this study.
Yes.
Okay. So do you have a CT sign, definitive sign? Try to help us to differentiate, to verify this possibility, this complication of being anterocolic fistula or not?
I don't know. Actually, I will search about it more.
Okay, you will search about this point. And now we will try to verify, to formulate your report, and I'll verify it.
Thank you.
Thank you, Iman. Good job.
Thank you.